Okay, we're going to pick up with the lung physiology. And we're talking about dry lungs. And let me make sure everybody understands that. I'm not saying there's no moisture in the lungs. You've got to have moisture at the respiratory membrane where alveolar wall and blood vessel wall come together. So, for example, right here is that respiratory membrane, or right here. That the second one is a blow-up of the first one. Okay, you've got to have moisture there because that enhances diffusion of gases. But you don't want the middle area, you don't want the inside area in the alveolus to have fluid in it, water, plasma. That reduces movement of gases getting to the respiratory membrane. So when I mean dry lungs, I'm talking about relatively dry, mostly dry. Now, in order for you to understand this, let me back you up to tissue capillary boundary. Now look at the picture on the right here. And I'm going to switch over to red since this is in yellow. It would be hard to see. Okay. So we talked about capillary dynamics before. Let me remind you. In the blood, which unfortunately they have done in yellow. Okay, so I'm going to redo it and make it in red. There is an outward force pushing plasma out, causing it to move out into the tissues. The tissues, as you can see, are these cells out here. Okay. And that outward force is blood hydrostatic pressure. It's the outward force. So that force, let me change to maybe blue. Okay, blood hydrostatic pressure is pushing fluid outward into the interstitial spaces, okay? Outward force. Blood hydrostatic pressure. And it varies along the area of the capillary bed. It's higher, remember, over at this end at the, oops, sorry, I'm reversed here. It's higher at this end. And it gets progressively lower as you come out the end over there. All right. It's about 35 millimeters of mercury at this end. It's about 25 millimeters of mercury out here. Okay. Now, that's blood hydrostatic pressure. Now, there's also a force inward. And the force inward is blood osmotic pressure, blood colloid osmotic pressure. And it is trying to suck fluid in. It's an inward force. Blood osmotic pressure, BOP. And remember, there are albumins inside the blood. That's what's causing that blood osmotic pressure. It keeps the osmotic pressure high, helps to pull fluid in. Now that is about, trying to remember, it's about 25, I think, normally. Now, let's go over here to this blood capillary on the left. Blood capillary alveolar area. Here's the blood vessel inside here. You've got a blood osmotic pressure, again, around 25, all right, pulling fluid in from the alveolus. The alveolus is here. And then you've got a blood hydrostatic pressure, which again is from the blood pressure pushing outward. And again, normally if we were over here in the tissue, it would be, 25 to 35 millimeter of mercury. But over here at the little tiny capillaries around the lungs, it's really low. It's only about 15 or so, even less than that. Now look at the difference between 25 and 15. You've got an outward force of 15. You've got an inward force pull of 25. What's your dominant direction of fluid? It's out of the alveolus towards the blood. So in other words, the blood is osmotically pulling any fluid as much fluid as it can out of the alveolus. That keeps the alveolus dry. So you end up with little fluid inside of the alveolus. Okay, moving on. All right, muscles. Bunch of muscles involved here. Let me point out some of these guys. Oops, I'm jumping around the place. Okay. All right, I'm going to change colors over to red. All right, so the two major guys, diaphragm. You see it right there. It's forming a kind of a dome-shaped thing within the rib cage. You can see bits of it. This is all the diaphragm. Okay, now on the left side are the external muscles overlying. All right, then we've got the intercostals. They're between the ribs, okay? Ribs right here. Intercostals are these short little muscle sections in between the ribs. All right, now we have internal and we have external. The externals, there's a direction of them. Notice the direction's going this way, okay? Look at my direction. Here are the fibers of the external intercostals, that way. On the other side, of course, they'd be going the opposite direction, inward. So the bottom edge of the muscle is attached to the rib below, okay? Remember your insertion and origin, right? Insertion down here at this end. Sorry for the writing. And origin of the muscle fiber up there. Okay, so anyway. External intercostals. Look over on the right. Notice, by the way, inspiration, muscles involved in inspiration here, and muscles involved in expiration on the right. Okay, the internal intercostals, they are underneath the externals, and look at the slant. They're slanting the opposite direction. Okay? Their direction is this way. The externals on this left side would be slanted this way. Okay? It's like taking your hands and running them across each other at kind of a 90-degree angle orientation. All right, then, those are the three major ones. Again, the major ones are diaphragm and external intercostals. They're the ones that are involved in inspiration. Normally, expiration is just a passive, just almost like letting a balloon lose its air if you don't have a knot in it. But if you have to eliminate air during an exhalation, it would be the internal intercostals that are primarily important. Now, when you do really forced breathing, if I told you to really do a long and a hard inspiration, expiration, you'd have to involve some other muscles. So remember your abdominis muscles, okay, abdominal, all right? I'm not going to go back over these. You had them in 2401. Scalenes, there are these guys right over here that kind of pull your rib cage upward. The serratus, right over here, kind of along the edges of the rib cage. Sternocleidomastoid, you already know what that is. It's a big big muscle, ropey muscle. You find forms a V shape on your neck. Let's see, I think I covered all of them. And again, all these muscles have their own little nerves going to them. Okay, so let me lay out what we're going to do. There are four things we're going to go through in the rest of this chapter. We're going to start with pulmonary ventilation. Oops. Pulmonary ventilation is the same thing as inhalation, exhalation. Ventilating the lungs, getting air into the lungs, getting air, high CO2 air, out of the lungs. Ventilation. We'll do that first. Now, when you inhale, air is going to fill up those alveoli. And now, the second thing we're going to have to do is get the oxygen across the respiratory membrane into the blood. That's called external respiration. It's the movement of the air molecules across the respiratory membrane into the blood. Now, if you follow an oxygen molecule through the blood, it gets pumped back to the heart, it goes out of the heart, it gets to, I don't know, a liver cell. And at the liver cell, where the blood capillaries meet the liver cells, that oxygen molecule has to now cross over the wall of the blood capillary into the tissues for them to use it. That's called internal respiration. Once the oxygen is inside the liver cell has to use aerobic respiration to make energy. That's cell respiration. You know cell respiration. You've had it before. In general biology, at least. Okay. So, everything we're going to do now is going to be pulmonary ventilation. Okay, so let's talk about what's going on with the lungs, what your lungs need to do. I use a balloon as an example a lot. It really does a good job in kind of mimicking a lung. So let's talk about forces holding the lungs against a thoracic wall. Remember, pleural fluid is in that space of the cavity between the parietal and the visceral pleural membranes. Visceral pleural right on the lung itself. You can't peel it off. It's actually forming the outer layer of the lung. The parietal pleura is the lining on the inside of the rib cage, on the inside of the muscles. And there's that thin fluid between them, pleural fluid. So when your thoracic cavity enlarges, that parietal pleura pulls out with your rib cage because it's glued on there. And the pleural fluid, which is kind of making an adhesive connection to the visceral pleura and the lung underneath it, pulls the lung outward. So that pleural fluid acts like an adhesive. When the rib cage goes out, the two pleural membranes go out, the lung goes out. It's kind of like, if you know what polygrip is, it's that adhesive between false teeth and gum. Anyway. Okay, so that's one thing holding the lungs against the wall. Also, gas there shouldn't be any gas in the pleural space. That helps to, you want that liquid adhesiveness. Okay, that's the main thing. So let's talk about what's trying to cause the lungs to pull away from the wall. Think about that balloon. If you blow it up, you don't make a knot, and you just let your fingers off a little, it's going to tend to collapse. It doesn't stay blown up if you don't keep your fingers on it or knot it. All right, so same thing here. You've got a recoil tendency of alveoli. There are elastic fibers around the alveoli. If you took a balloon and you take about 10 rubber bands and you put the rubber bands in all different angles around the alveolus, around the balloon, you've got the setup here. And those rubber bands are kind of pushing inward, causing the balloon to try to deflate to get smaller. It's the same setup in your alveoli. They're trying to press down in on the alveoli. So the alveoli have a tendency to recoil and go back to small size. There's another thing that is trying to make the lungs smaller, and I've kind of mentioned it. I want to spend more time on it now. Surfactant. All right, so I'm going to draw an alveolus here. Here's an alveolus right there. Okay, so here's air coming down, and remember that the air that you're breathing has some water, has moisture, is humidified, right? Okay, so here's some water molecules, all right? Now, what do you know about water molecules? Water molecules, here's some water molecules, tend to attract each other by hydrogen bonding. Remember that? They are attracted towards each other. And these water molecules will pull together by hydrogen bonding between oxygen and hydrogen to form the very smallest cluster of water molecules. Look at the difference between left and right. Okay, see how the water molecules have pulled into like a little cluster? That's happening in your alveoli. This is called surface tension. Now, sometimes surface tension is good, but it's not good in the alveoli because this change in the water molecules to pull inward towards each other I can't really change my little water molecule patterns in my alveoli, but if you think about them all kind of moving in towards each other like this to try to cluster like they did over here, what would happen? It would pull the alveolus inward, right? So it would promote or enhance the possibility of collapse of the alveoli. Because remember, every time you exhale, the alveoli get smaller anyway. If you had this inward force, it would surely cause them to collapse. So instead of this scenario, here's another alveolus. Here are my water molecules right here. You got surfactant. Let me change colors. I'm going to use green. All right. So surfactant is forming a kind of a layer on the inside right in here. Remember, it's made by special cells on the inside of the alveolus. And this surfactant breaks up the surface tension between the water molecules, so you do not get this situation. It's every water molecule for himself. That's the importance of surfactant. The big problem with surfactant is if you don't have it. There's not too much, it's not enough. And who doesn't have enough? Well, I'll give you a hint. You make it very close to your birth and thereafter, in a very short amount of time. If you're a newborn baby, think how much energy is put towards breathing. You hardly even think about it now, but a baby, newborn, has to put a lot of work towards breathing. If the alveoli tended to collapse because of a lack of surfactant in this newborn, it would take the baby a lot of energy to try to inflate the lungs the next time it inhaled. Now, let's go even to a worse scenario. Premature baby. Got other health problems? Weaker? This is a bigger problem now for that baby. So that's called respiratory distress syndrome in an infant. Okay, let's go on. Pressures. Atmospheric, intrapleural, intrapulmonary. Atmospheric, outside pressure. You can't do anything about it. It's 760 millimeters of mercury, pretty much. Well, at least in Dallas. That's one atmosphere. That's at sea level. We're actually 500 feet or so above sea level. It's not exactly 760, but we're going to just play like we're in Corpus Christi or Galveston. Okay, intrapleural pressure is in this space. It looks like a blue film. There's your intrapleural space. I didn't mean to point towards atmospheric. That's intrapleural. Okay, intrapulmonary is the pressure inside of each and every alveolus. Now, there's not much difference here among these pressures. Intrapleural is always less than the other two. As long as there's fluid in the space. The two most important are atmospheric and intrapulmonary pressures. Now, let's talk for one more minute about that space. I mentioned in the pleural space it's supposed to be liquid. It has a low pressure. Now, let's say that there is a knife wound. Okay? We're going to turn to black here. Here's a knife, stab wound right there. Air, there's now an opening to the outside. So, get rid of this knife wound. Now I have an opening right there. And what's going to happen? Air from out here now goes into this space. Now remember, I mentioned that this intrapleural pressure is supposed to be lower than atmospheric and intrapulmonary. But remember, the pressure is going to be high out here in the atmosphere. So air moves from high pressure to low pressure. The air goes into this space. What's that going to do? You're not supposed to have air in that space. It pushes down on the lung. It's going to tend to collapse it. Look over here at this X-ray. There's your collapsed lung right there. You don't see one over on the right. That's because it's there. It's filling up this entire space right here. Here's another example. Look at this one over on the right. There's the lung right there. It's collapsed. And this thing where I put an asterisk is a space from the collapsed lung. That collapse is called atelectasis. You're going to need to know it for nursing. Now the entry of air, this black arrow that I made right here, up here at the top, that black arrow, the entry of air is called pneumothorax. Once the air enters, that will put pressure on the lung to collapse. The collapse is called atelectasis. Pneumothorax causes atelectasis. They're two very different things, although related. Okay. All right, so we're going to move over to what makes you take air in and out. All right, you got a thoracic cavity. You can see the diaphragm well. Okay, Boyle's law. You have got to know this. Got to. Pressure in a container is equal to 1 over volume. Now, this is not a math formula where I'm going to give you values and you have to figure it out. Basically, it says that if a volume of a container goes up, then, let me put an if in front. If the volume of the container, like the lung, goes up, then the pressure in that container will go down. Inverse relationship. If the volume of the container goes down, then the pressure in the container goes up. That is Boyle's law as it pertains to here. Okay, so look at this left scenario right here. No, let's start over here on the right. Okay. Look at the diaphragm. Here is resting right here, all right? Your diaphragm is a dome-shaped muscle. There it is right there. That's the resting state. Over here on the left, it's contracted. On the right, it's relaxed. Okay. Now, the lungs are in purple. They're in a thoracic cavity. So when your thoracic cavity expands in size and your lungs go out with it, remember the adhesion at the pleural cavity? The lungs will get bigger, correct? So what happens to the volume? The volume increases in the lungs. What will happen to the pressure in the lungs? Goes down. So look over on the left. You can see that the volume of the lungs has gotten bigger. When the volume gets bigger, pressure goes down. Why do you care? This is intrapulmonary pressure. What we're going to do is cause the pressure in the lungs to be lower than the pressure in the atmosphere. Air moves from higher pressure to lower pressure. Air goes into your lungs. That's the importance of Boyle's law. Okay, so obviously muscles are involved here. All right, I've said this before. When you inhale, that's active contraction of the muscles. The diaphragm, let's see, kind of hard to see the diaphragm here, but there it is right there, forming that dome right there. There's the diaphragm. And your external intercostals right here, these guys right in here, 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 and so on. Okay. They have to contract. Now, this is quiet, just normal breathing as you're doing now. When you exhale, those muscles relax. That's all you need for exhalation. You need no muscles to contract to make you exhale. It's like letting go of the neck of the balloon. The air goes out. You don't have to push on the balloon, anything like that. That's in normal breathing. Now, in forced breathing, it changes. You have to have more muscles involved. So inspiration is active. Expiration is passive. Okay. By the way, in the right-hand shot, you see, again, relaxed. Look at the diaphragm. It's really high right there. And over here in the inhalation side on the left, you can see it's been pulled downward. It's flatter. Keep that in mind. Okay, so let's go through the steps. Inspiration. We've got to make intrapulmonary pressure a smaller number than atmospheric. In fact, atmospheric, again, if we're at 1 atmosphere, sea level, about 760. All we're going to do is we're going to drop pressure in the lungs by only maybe 1 to 4 millimeters. It's not a heck of a large drop, but that's all you have to do to get the air to come in. That's it. Okay, so the first thing we have to do, those two muscle sets have to contract. Once that happens, your rib cage moves upward because of the external intercostals contracting. Your rib cage moves upward, and that makes the depth of your rib cage increase. And it also moves your rib cage outward, so you have a wider diameter, sideways as well as depth. And your diaphragm pulls downward, so the vertical length has increased of that cavity, of the thoracic cavity. We're talking about the thoracic cavity. Now, we've increased thoracic cavity volume. All right. Now remember, adhesive quality between the lung pleura that's covering the lung and the parietal pleura that lines the inside of the thoracic cavity holds them together. So when you increase the thoracic cavity volume, the lungs come out with it. Okay? Lungs get pulled out. Now the size of the lung volume is increased, and that drops the pressure. Here's your Boyle's law right there. Okay, so now we've dropped the pressure in the alveoli, air comes in. One step causing another step, causing another step. Okay, let's go expiration. Now we've got to make intrapulmonary pressure 1 to 4 millimeters higher than atmospheric pressure, so the air will go out. Okay, everything is reversed, we just talked about. Diaphragm and external intercostals, relax. The thoracic cavity goes inward, and the lung, the alveoli, because of that elastic tissue around all the alveoli, recoils. The volumes of those two areas decreases. Remember Boyle's law, decrease volume, increase pressure. Pressure goes up a few millimeters. So now intrapulmonary pressure is higher than atmospheric pressure. Air goes out. Think about this. We're going to talk about this in class. That's pulmonary ventilation. Okay, some things that can affect it. Loss of surface area. Look at this shot of emphysema. You got it on histology. That's not normal lung tissue. The alveoli are ruptured. It looks like balloons that have popped. There are far fewer alveoli, less respiratory membrane for gas diffusion. Surface area, first surface area, first surface area. Pressure gradient. Your body, the pressure in your body versus the pressure in the atmosphere. So if you are here breathing, it's a lot easier to get oxygen into your lung than if you're up at 15,000 feet on Pikes Peak, at the top of Pikes Peak. Same person, you go up to Pikes Peak, 15,000, it's going to be harder to ventilate your lungs. That's what I mean by pressure gradient. There's less pressure up there. High altitude, low pressure. Respiratory passage resistance. If you got a button in your bronchi, you've got mucus in your bronchi, anything that disturbs the flow pattern in the airways increases resistance. We've talked about that in blood vessels. Lung compliance, the ease with which you can expand your lungs. Think about it, blowing up a balloon. Easy. You take a breath, you blow up the balloon. Okay? If the balloon had way more rubber in the walls, if the walls were thicker on the balloon, it would be much tougher to blow it up. So you want good lung compliance. That means the ease with which your alveoli can expand. You also have lung elasticity, though. Remember that recoil due to elastic fibers? You want your alveoli to recoil when you exhale. Another thing is surface tension. We've talked about that already. You want little surface tension. Surface tension in the alveoli is not good. So I've talked to you, already showed you emphysema, showed you this little picture. And by the way, the picture down here is emphysema. in a autopsy of somebody's lung. Emphysema increases resistance in the passageways. It causes you to lose alveolar surface area. Hyaline membrane disease. Remember I talked about respiratory distress syndrome in infants due to a lack of surfactant? That's the same thing as hyaline membrane disease. Okay, let's stop here.